With today's briefing, and because we cannot yet visit Israel in person, we are thrilled to bring the best of Israel's innovation directly to you. And with that, it's my pleasure to introduce Dr. Eyal Zimlichman, the Deputy Director General, Chief Medical Officer, and Chief Innovation Officer at Chaim Sheba Medical Center. Dr. Zimlichman is an internal medicine physician, a healthcare executive, and a researcher, focusing on accessing and improving healthcare quality and value, patient engagement, and patient safety. He's also the Chief Innovation and Commercialization Officer of Sheba's ARC Innovation Center, a center which he began, and whose acronym expresses the center's strategy to accelerate innovation that will redesign healthcare by collaborating with partners. His research has won international acclaim, and we are thrilled that he's agreed to speak with us about his work in combating COVID-19.
Thank you, Nisha, and for this introduction. I'll share my slides so I can share with you some of what we've been doing. I'll start by saying a few words about Sheba. I'm sure some of you are not familiar with it. Sheba Medical Center is the largest hospital in Israel. Not just the largest in Israel, it's also the largest in the Middle East and one of the largest hospitals in the world. It has about 2,000 beds, and on one campus we have an acute care general hospital, a children's hospital, a rehabilitation hospital, a women's hospital, and a cancer hospital, all on one campus, with about 10,000 employees working day to day at Sheba, 24,000 cars that come into our Sheba city on any given day, 4 hotels, 2 shopping malls, and even a lake, as you can see here in this aerial photo. So not the typical hospital. It's situated just outside of Tel Aviv, it's actually part of Ramat Gan, so about maybe 15, 20 minutes from Tel Aviv city center. And one of the things that really is different about Sheba is that we don't have any real estate problems. We basically can build almost as much as we want, which is always nice to have when you're such a large hospital. The other thing to mention, as again was mentioned before, is that we were just named number 9 hospital in the world by Newsweek. Newsweek magazine started in 2019 to rank hospitals, and in 2020 they ranked 2,000 hospitals worldwide, and out of the 2,000 we came in as number 9. We're very proud of that achievement, and I think all Israel is very proud of this achievement as well. It's not many institutions in the country that we have that are ranked top 10. And in many ways, the footprint of Sheba, not just on a national level here in Israel, but also on a global level, is really something that's extraordinary. And I think we're very happy that Newsweek really actually saw that and ranked us as number 9. So ARC was mentioned, and maybe just say a few words before we dive into COVID about ARC. As Nisha mentioned, ARC stands for Accelerate, Redesign, and Collaborate. It's a new strategy to accelerate innovation with one goal in mind, and that is to change healthcare completely within the next 10 years. We've set a goal of redesigning healthcare, that's the R in ARC, redesigning healthcare by the year 2030. To do that, you cannot do this alone. No one hospital in the world can achieve this task of changing healthcare in 10 years. And we understood very early on that we need to actually build an ecosystem of partners that will be working together towards this goal. And this is what ARC is. ARC basically is built on 4 principles. The first one is that if we are going to change healthcare in the next 10 years, what's going to be the change vehicle to get us there is the focus on digital health. Digital health will be the biggest game changer in healthcare that we've seen in a very long while. Just like digital health has changed the banking industry, for example, it's going to make a huge difference in healthcare and how we conduct healthcare in the next 10 years. So we're focusing very much on digital health, although we're still working on other areas like pharma and medical devices, but digital health is the strategic focus. The second principle is open innovation. Open innovation basically saying that we're not only looking internally to innovate, but we're also looking externally to find industry partners and startup companies that have what we need and have solutions that we think will play a role in this redesigning of the healthcare system. We bring in those startup companies as ARC members, and we have built ARC as a startup-friendly environment with one thing at mind, and that is to accelerate the development of the most innovative startups and make sure they have everything they need 360 degrees to take them to where they need to be and where healthcare needs to be. And that is the open innovation nature of ARC. Third is international collaborations. As I've mentioned, ARC is an ecosystem. It's not just Sheba. And in this ecosystem, we have many, many members. Some of them are academic medical centers. And these are quite the leading academic medical centers on a global scale. Places like Stanford and Mayo Clinic and Mount Sinai in New York and Brigham and Mass General in Boston, Henry Ford in Detroit and Thomas Jefferson in Philadelphia and Cedars-Sinai in Los Angeles and McGill in Montreal, Sunnybrook in Toronto. A very long list of the leading academic medical centers that actually are working as part of ARC, geared up towards the same goal and the same vision of changing healthcare. And that's critical for ARC, and that is to buy in on that vision that we have. We also have industry partners that play a role. These are companies like Microsoft, Johnson & Johnson, Merck, AstraZeneca, Boston Scientific, and others, large companies that work with us to find solutions to the problems that healthcare has, again, towards that common vision. And lastly, it's the innovation infrastructure. When we talk about infrastructure for innovation, we're focused on three areas. One is the regulations and policies that govern institutions, and we're taking a very proactive approach to changing the policies that govern us to make them much more flexible, to make them much more towards pushing innovation, accelerating innovation. That is a critical element of ARC, changing the rules and regulations rather than just being passive and working with what we have. The second piece of the infrastructure is the data infrastructure. We've invested a lot in organizing the data, structuring the data, and so on. Sheba is one of the most digital hospitals in the world. We've been completely paperless since the year 2004, which means that we have a lot of electronic data on the patients that came through Sheba. We see about 1.6 million patients every year. Multiply that times 16 years of being completely digital, and you have a whole lot of information and medical data, which you know now is the new oil, as we say, in healthcare, and the data infrastructure is critical. And lastly, it's the physical infrastructure. And this is critical as well to streamlining innovation. What you see in this photo is how our innovation campus is going to look like by the year 2025. This is actually a work in progress. 5 buildings, a total space of 300,000 square feet of innovation space, an underground parking of 6 floors. All of that is the new ARC campus. It's being built right now. We've already built two buildings out of the 5 that are planned, and we're operating from these 2 buildings as we speak. But as I've said, this campus is a work in progress, and hopefully we'll have everything ready by 2025, and I invite you all to come and witness. We get a lot of international visitors when we're not, of course, inside a pandemic like we are right now. So hopefully we'll get back to that very, very soon. So this is ARC, and this is what we're focusing on day to day before COVID struck. All these areas, basically a part of digital health that we're focused on. And I don't have time to go into some examples of what we're doing. You see here on the slide, this is a topic for another conversation. But of course, I was asked to focus on COVID, and this is what's on our minds, of course. And this is ARC before we jump into COVID. This is the ARC ecosystem. And you see here the international collaborations, the corporate strategic partners, the startups. This is a partial list, of course, and the academia that we work with here in Israel. And this is working as one, as a part of an ecosystem to change healthcare. This is what ARC is all about. So as you know, about 3-4 months ago, we came into this new situation, and we had to make a decision. Is innovation essential or non-essential in times of crisis? Doctors and nurses are all essential when we're fighting a pandemic. There's no question about that. But what about engineers? What about data scientists? What about project managers? Are they essential, or should they stay at home on leave from the hospital? It took us a couple of minutes to make a decision. Pretty quickly, we understood that innovation is not just essential, but it's critical if we're going to win this war against COVID-19, a war we're still waging, of course. And what we've done is we've made a decision to focus completely on COVID, to put a hold and a pause on all the activities we were working on before and completely focus on COVID-19. And we actually declared battle mode. We're using a lot of militaristic terms here in Israel, as you know. So we announced battle mode at ARC. And you see here on the left corner of the slide, we came up with this new logo, ARC COVID-19 battle mode, to signify this is what we're focusing on currently. This is where our attention is going. And we came up with this new game plan of working towards solutions around these areas, data to come up with more discoveries on this disease we're just learning how to cope with, ventilation solutions, because that was an issue, as you know, and still maybe will be an issue in the future of running out of ventilators when we get many severe patients. We needed to come up with solutions for ventilation, diagnostics, to be better able to diagnose the disease, telemedicine solutions, which of course, we talked a lot about that in the past few months. I'll mention what we're doing here, therapeutics and mobile solutions as well. So to start, one of the first things that we needed to come up with was a solution. The staff, as you know, when they're treating patients, there's that problem that they might contract the virus. And this is critical because as we get staff that contracts the virus and becomes sick, that puts the staff, of course, to be non-functional. And when you have a huge load of patients, you need all your staff to be able to work. So how can you provide high-level medical care on one end with minimal physical contact on the other? This was the first challenge we were faced with. And as Nisha mentioned before, when we received the first COVID patients to Sheba, we made a decision to build the Sheba isolated corona unit. This was the first corona unit. We've built it in a time of about 48 hours, 40-bed unit, 40. And what you'll also see here is that apart from this building that you see, which is again the corona unit, we've had this other, I don't know if you can see my mouse, my pointer, but on the left side, there's this other structure, which was actually a tent. We've built from our emergency hospitals that we deploy in times of emergency, usually in earthquakes or some other natural disasters. When we come in to help, we build tents. And we've built a tent, and you'll see how it looked like. But we had most of the clinical staff in the tent treating patients inside the building a few meters away because we wanted to minimize contact. I'll show you a short video. Hopefully, you'll see it on your end. It's only about 1.5 minutes. We'll give you an understanding of what we've been doing here, the zero physical contact telemedicine at Sheba. So a couple of things that we've done there. You see this teletent again with the clinical staff in the tent caring for patients. How that was done, I'll show you some of the technologies used. One was being able to monitor those patients. As you know, COVID-19 patients can be very mild with very mild symptoms for a while, and deterioration can be very rapid, and they could end up in a life-threatening situation in a matter of hours. It was critical for us to be able to monitor those because patients in this unit were basically mild to moderate patients. If they became more severe, they had to be transferred to our corona intensive care, which I'll show you in a few slides. And we needed a technology that allows us to continuously monitor heart rate, respiration rate specifically, because respiration rate was the most important life sign that we could measure here. And we used a technology that already existed called EarlySense, built for hospitals and intended to detect early deterioration of patients hospitalized in the hospital. It has an artificial intelligence-based algorithm that predicts clinical deterioration based on the contact-free continuous monitoring of vital signs like heart rate and respiration rate. The sensor you see here in this picture actually is placed under the mattress and measuring everything about the patient who's lying in bed. We've used that technology, and we found that it was very accurate in identifying patients that are deteriorating. We're now looking at the data we've gathered with the patients that came through the units, and we're even writing a scientific paper about the findings of this type of technology. Another technology that you've seen, maybe have heard before, sorry, is a technology called TytoCare, a company that has a device that allows the clinicians to examine patients from afar. You could actually listen to the heart and lungs of a patient. You can actually look into the throat or into the ear. You can look at skin lesions, and you could make diagnosis and make this treatment decisions based on examination done from afar, typically used for patients at home where the doctor is in the clinic and we're trying to save the patient the time of traveling, and we could examine him from afar. We have used this technology inside our corona unit. This is Dr. Gadi Segal, the head of the corona unit, and he's examining patients from the teletent. He's listening to the heart and lungs through the headphones. He's looking into the throat of a patient, and he makes clinical decisions based on the findings. This was the first time this type of technology was used in hospital rather than at home where this was originally designed to. Robots, we've been using many types of robots. This is one of them. The robots have been before. We haven't invented the robots. This is the InTouch telepresence robot. It allows the doctors to actually maneuver it with a joystick between the different patients in the ward and be able to come up to the patient and converse with the patient through the screen, and also examine the patient through the technology that exists on the robot. Again, the idea was minimize contact between staff and patients so that we minimize the danger for the staff to contract the virus. We even packaged that together, the monitoring technology, the physical examination, the management tool. We use Datos, which is our telemedicine platform designed here at Sheba, and the company Datos is now available with this technology elsewhere, but we've packaged that also to use it at home. We call it the Zero Touch Telemedicine Toolkit, and as you'll see in this slide, what we've done is we've packaged that in a box. The box was taken to the patient at home who was found positive with the virus and needed hospitalization, but his condition was mild. He could be hospitalized at home. When the patient receives the box, the technology is inside. They open the box, they have some instructions of what to do with what, and we can treat the patients every day. We examine the patient from the hospital when the patient is at home. After a few days, if something is wrong, we need to bring the patient to the hospital because his condition is not improving. We send an ambulance to pick him up, or if everything is fine, he is discharged from hospitalization at home. He puts the technology back in the box, places the box at his doorstep. We send somebody to pick that up, go through sterilization, and use the technology again for the next patient. This has actually been working very well and has created a lot of attention worldwide because at the end of the day, we're trying to keep patients from coming to the overloaded hospitals. And if a patient is in a mild or even mild to moderate condition, we can treat him at home from the hospital without having the patient come to the hospital and taking up a bed. We looked for many ventilation solutions. I won't have time to go into everything that we've been doing, but I can tell you one thing. Together with one of the secret units in the intelligence corps in the Army, the IDF, we've designed a ventilation solution that I think today is probably the most superior ventilation solution in the world to replace ventilators. So of course, if you have a ventilator that was FDA approved and it's an off-the-shelf ventilator, you're always better off with that. But in a condition where you're running out of ventilators, we think this is the next best thing to a ventilator. We've developed it together with the Army. We've patented it. We've even commercialized it. And the Israeli Air Force industry actually is now creating these ventilators and selling them around the world to hospitals that need this type of technology. We actually have 100 of these in a warehouse at Sheba, just in case we'll need them in times of emergency. Hopefully that time never comes up, but you're better off prepared for these types of incidents. Our tele-ICU, we've built a 100-bed ICU in an underground garage beneath the Women's Hospital at Sheba. It took us 72 hours to build the ICU. Quite incredible. We have some videos that show us how we're doing it. It's a very advanced ICU with all the advanced technology, with the robots I've mentioned before, telecommunication tools that allows us to communicate with staff that are protected with the suits, of course, allows us to communicate with patients. And also, as you see in the screen in the middle, artificial intelligence solutions that allow us to monitor all the patients in the unit, up to 100 patients, and understand which patients are doing very well and are predicted to be discharged, which patients are not doing so well and maybe are predicted to develop complications, and what kind of complications are they predicted to develop. We use this type of technology. It's a company that we work with called Clue Medical, and the company, just by the way, the solution became FDA approved just about 2 or 3 weeks ago, based on this on the data here from Sheba, and it's one of the successes that we think can be used around the world for other hospitals as well. Teleteaching, we work with Microsoft. I mentioned Microsoft is one of the partners at ARC. They allowed us to be the first hospital outside of the US to use this most sophisticated technology. It's called the HoloLens 2 for for augmented reality and virtual reality. And we used it for remote teaching and remote guidance. I'll give you an example of how that works. We have, let's say, a nurse caring for a patient inside a closed COVID unit, and the nurse now has a problem to operate a device like a monitor or a ventilator. Typically, we would bring in a technician, but bringing in a technician exposes that technician to the virus, of course. So the idea is that that nurse puts on the HoloLens and then is being guided through the technician when the technician is at his office, guiding the nurse how to operate a problem with the ventilator or the monitor or any other technology. And again, saving us the need to send more personnel inside and expose them again to the virus. We did a lot of work with thermal and contact screening using AI, artificial intelligence solutions. For example, we used, we're working with a company called AnyVision. We used them to look at our security cameras. You know, these are cameras that we have everywhere today, right? In shopping malls, on streets, in shops, everywhere. The hospitals have them too, in public areas, in corridors, in waiting rooms. We have about 700 around the Sheba campus, 700 cameras. And we use this AI solution on top of the videos coming from the 700 cameras to identify contacts between a positive patient or a positive staff member to other staff members who might need to go into quarantine because they were in contact with a positive person. Typically, these kind of investigations take about a day or two to conduct. With the AI assistance, it takes 2 hours. And this is a game changer. We're using it right now at Sheba, and this is something, again, that can be used in other locations around the world as well. And this is really cutting-edge technology using AI to enable us to better understand contacts and maybe how the virus is transmitted from one person to another. We did a lot of work around data as well. We actually uploaded to a cloud, to a secure cloud, very protected, of course, all the data of all the COVID-19 patients treated at Sheba. Of course, everything is de-identified. There's no identifying information of these patients. And then we allowed about 40 data groups in Israel to work on this data. The idea was, let's bring in as many talented people as we can to work on our data and come up with new insights using artificial intelligence and other solutions to learn more about this disease, which is a new disease to everyone. Come up with new insights, understand better why specific patients deteriorate and others don't, why specific patients have a very bad disease and others have a very mild disease. And actually, we've had a contest at the end where from the 40 groups, we came up to the 6 finalists who presented their solutions. And at the end, the data team of Intel won first place. And the prize for first place is that they're going to be implemented inside the IT systems at Sheba and will have a chance to save lives. At the end of the day, the 40 teams that came up didn't do this for money. They came because they wanted to save lives, and the winner gets a chance to do exactly that, be implemented and have clinicians make better decisions and hopefully save lives as we go through this pandemic in the future. Really tying it all together, and bringing it back to ARC. It's the ARC strategy in times of crisis that we think allowed us to work so well within these past 3 months. The acceleration in a very short while, the ability to design something from concept to product in about 2 months is really unparalleled. And ARC was really built exactly towards that. Redesigning, thinking outside of the box, using technology intended for one use, but now using it for another, like the AI on videos, originally used for other purposes, now used to understand better contacts between personnel. And of course, collaboration. We've collaborated with so many different organizations. You see here in this small photo, a couple of people from the IDF sitting with us in my office, thinking with us about solutions to problems that we have. And we're working with many different industries. A lot of this in Israel has to do with the defense industry, and some of you who are following the news know that the defense industries in Israel played a major part in coming up with a couple of those solutions, because they were completely focused on coming up with solutions for COVID, and they worked very closely with ARC to come up with many of those solutions. We wrote about 17 different patents in 2 months and came up with 40 different inventions that we carried through within the span of 2 to 3 months between March to the end of May. So this is really unparalleled, and really the ARC strategy allowed us to take this to this level. I told you about ARC, the ARC hubs. This is what before COVID we were focused on. This is what we did in battle mode with ARC COVID-19. And as we transition out, and hopefully we'll transition out very quickly, we thought here in Israel we're out of the storm. It seems like we're going through a second wave right now. But by the time everything will be said and done, and I assure you this time will come, this is what we're thinking, that this will new ARC Corona, the ARC Corona hub, will be the new hub, the 7th hub at ARC, because what we've done here and what we've learned here cannot stop here. We have to take the learnings to the future. We have to think about more solutions and be much better prepared towards the next pandemic. And pandemics will come. We don't know how soon, but pandemics will come, and we want to make sure we're much more ready for it the next time it comes around. So I'll end with that. My contact details, you see here, the email, you can drop us a line. I will be happy to follow up and do any collaborations, provide any more information as needed. Thank you very much.
Thank you so much, Dr. Zimlichman. That was fantastic. We at AJC, and especially at Project Interchange, know how much Israeli innovations have done to enhance the lives of people all over the world, whether it's in agriculture, medicine, water, you name it. And the Sheba Medical Center seems to exemplify Israel's seemingly infinite ability to come up with new out-of-the-box solutions to pressing global problems in about 1/100th of the time that other folks take. So, you know, kol hakavod, congratulations for that. You're doing amazing stuff. Your presentation covered so many areas, and we want to make sure there's lots of time for question and answer. So I wanted to start with you by asking, given the current trends now in Israel and the spikes, which we know are happening in Europe, the United States, and elsewhere. Do you think there is a way to realistically think about containing the virus in the absence of a vaccine or effective treatment? Israel did such a great job of flattening the curve over the last 3 months. What steps can and should the Israeli and other governments take now to try to contain the virus? And with evidence accumulating about the huge numbers of asymptomatic transmission, is containment the appropriate goal right now?
Well, I think this is really the big question, right? I think that as we look into the future, we won't be able to really handle this completely before we get an effective vaccine. I am pretty optimistic about having an effective vaccine come out because there are dozens and dozens of companies now all working towards the same goal, and each one has a different solution. So if one fails, one of the others will probably be the right one. We don't know which one. We know, the Moderna one, which is probably the first, is going to come out hopefully around before the end of the year. But then many others are going to follow in the months right after. So even if one fails, again, I think one of the others will be successful in doing the job. But until then, I think this will continue to be a problem. Our only hope is to try and contain it in a way that the numbers are very low, well below our capabilities to manage it. Some countries are succeeding in doing it. If you look at countries that did very much like Israel, like Austria, for example, like Denmark, for example, they had their first wave, which wasn't that big as it was in other countries like Italy and the UK and the US, especially in the New York area. But they had a first wave, which was quite mild, and then they came down to about 0, which was the same as was in Israel. When you open up, and you have to open up the quarantines, because otherwise you understand the financial impacts of that, of course. When you open up, you have to do this in a fashion that allows things to stay in hand. In Israel, our main problem was the education system. When we opened up the schools in Israel, and you probably know this, are pretty crowded, and that's where things started going in the wrong direction. So I think every country needs to understand where the problems are, what needs to happen, what can we open, what probably is better to stay closed. For example, large gatherings. You could sustain the economy and still forbid large gatherings. That's fine. But you cannot do well with closing restaurants and other businesses. So you need to make those decisions, and then there is a way to contain it. There is a way to keep the numbers low. And this would be a work in progress, and we'll need to learn from one country from the other, what worked, what didn't work, what went wrong in some other countries versus what was very successful in others, to see how can we carry ourselves from now to where the vaccine will be effective. We probably will not see the herd immunity. That would take maybe 2 to 3 years to happen. So I'm hopeful vaccine will come well before that. And I think we need to get ready towards about a year to maybe a year and a half from now until we'll be out of this.
Great. I know there are many more questions that I would love to ask you and take the prerogative of asking you, but that wouldn't be fair to those who've called in. So I'm going to turn it over to Zach to begin to dive into the questions that have been submitted by alumni. Zach?
Sure. Thank you, Nisha. We do have a question coming in from Rita in Los Angeles, who asks, you mentioned many innovations Sheba and ARC have created amidst the COVID-19 pandemic. What innovations do you think will stay and spread around the globe even once the coronavirus threat diminishes?
Great question. I think we talk a lot about this, and we have to mention it. This is area of telemedicine. I think telemedicine, we might look back a couple of years from now towards this event, the COVID-19 pandemic, and think about this as the turning point of telemedicine and digital health at large. The watershed period, because what we've seen here is because people couldn't come out of their houses and their homes, and because we had this issue of trying to protect the staff and minimize contact, much of the clinicians had to use digital health technologies. At Sheba, we had about 100 virtual visits a day before COVID, and right now it's gone up to about 1,000 virtual visits a day, which means many of our clinicians that were skeptic of digital health and telemedicine and thought, nothing really replaces the human touch, being in the same room with the patient, and also patients alike. When many patients said, I don't want to see my doctor on a screen. I want to be able to get to his office and be in the same room with him and, have him examine me. We understand today, everybody that has gone through this experience understands today that telemedicine has a lot more to offer. And doctors are now realizing that they can examine patients from afar. They can make good clinical decisions from afar. And patients have now realized that many of their problems and answers can be answered without having to stand in traffic to get to the hospital, looking for parking, and waiting in a waiting room for I don't know how long to see your doctor. You could do this at the comfort of your own home. So these advantages, the fact that we've seen that, and we see that, we say in Hebrew, the demon is not that bad. That fact, I think, will stay with us for many, many years. And we'll see much more telemedicine into the future than we've seen before. We assumed before that it will take us about 10 years to really transition the healthcare industry from actual visits to virtual visits, much like the banking industry has gone through this change. Just a couple of years ago, we used to go to the bank to do everything. Today, if they tell us when I want to do something, they tell me, listen, you have to come to the actual bank. I never like that. Why can't I do this online? This would be medicine. And it wouldn't take 10 years as we predicted before. It'll probably take 2 or 3 years because of COVID. So that will change completely, I think, in the next few years.
Thank you, Dr. Zimlichman. We have another question that came in. This is about going back to school. Many universities, many US universities, like Israeli and other universities, are dealing with how to conduct classes. Some have announced a mix of socially distanced in-person and online courses. Based on your medical experience, without getting into political issues, and knowing that the situation is ever evolving, what do you recommend?
So again, there's no one answer to that because it very much depends. I'll give you an example with, with schools here in Israel. Again, I've mentioned that before. If you compare Israel to Austria or Denmark, one of the major issues, differences between these countries that played a major factor in the rolling and the changes we're seeing with the numbers with the COVID pandemic is the how crowded are the classes. In Israel, some of you know this, we probably have between 30 to 40 students in one class in elementary school for many, many reasons. On day-to-day, people see sometimes the advantages of that. One big happy family, very much Israeli in nature, everybody knows everybody, and these type of things. In pandemic, that's bad. That's very, very much the difference. In Denmark, in Austria, in the US, in many ways, maybe 15, 20 students in a classroom. When you have 15 to 20 students, you can have social distancing. If they all keep their masks on, great. You could have school in person. But if people don't keep their masks on and they don't keep the 6 feet or 2 meters between one to another, then it won't work. And you're going to have a lot of acquisitions, and then students take that home, of course, the virus with them, and the parents get the virus, and from the parents to the grandparents, and we know what happens then. And so it all depends on how much you can manage it. Some countries have shown that it is doable. In Israel, again, because of the crowding of classes, it didn't work. And it's a great question even here in Israel, what happens in September? You know, we're now going into the break, the summer break. What happens in September when they need to come back to school? I've been, speaking about this here in the local media, saying that we cannot go back to school in September into the classrooms. We have to make sure that we use the 2 months we have right now of summer to make sure we can do online teaching for kids here in Israel and make sure everybody has a tablet or a laptop because there are, of course, socioeconomic differences and so on that we have to solve. So I think we need to be busy these 2 months.
Thank you. And we have one final question, and I actually think this is a great way to close it. We have Rick in Milwaukee, Wisconsin, who's asking, you mentioned with all that is going on in the world today, and the work that is being conducted at Sheba and the ARC Innovation Center, what gives you the greatest hope for the future?
Well, there's a lot. I usually talk about, this is obviously COVID-19 has been a tragedy for many of us, and it's nothing to really take lightly, but I try to look at least the quarter full glass, or maybe it's a fifth full glass, but there is optimism. There are opportunities, and we need to embrace those opportunities. I mentioned telemedicine as one. I think healthcare will grow stronger from COVID-19. And of course, it affects all of us. We all, hopefully we won't need it too much, but healthcare is a central piece of everybody's life. And healthcare will grow stronger coming out of COVID. So I think if we try to find the optimism, if we're trying to look for the opportunities, I think what we're going to see is many new inventions, many new discoveries. We're going to learn so much about viruses that this will help us so much battle the next pandemic that comes across. We're going to find solutions to some of the viruses that we currently don't have solutions for, like hepatitis and other viruses. It's many cases like times of war. I don't know how many of you know this, but in World War II, with obviously huge amount of tragedy, especially to the Jewish people, one of the things that came out of World War II is antibiotics. Antibiotics was invented in World War II because of the race to find a solution to wounded soldiers in the field with their wounds being infected. And how many people has antibiotics saved since the 40s till today? Obviously in the millions. So let's try to look for the opportunities. We will win the war on COVID-19, and we will come on to the other end stronger and more ready towards the challenges ahead.